important thing to consider is interference from other electrical devices and other apparatus in the operating theatre. At this stage, it's important to turn the diathermy machines off to make sure that the operating table itself is turned off, to make sure that the warming blankets are off, and to keep people's mobile phones and other devices well away from the patient and the machine. This is the neurologist looking at patient's movement, both active and passive. If the microelectrode is passing through a kinesthetic cell, then the microelectrode recording will vary with patient movement. At this stage, we're also attempting to get a baseline in terms of their tremor, rigidity, and bradykinesia, so that we can interpret changes which occur with electrode placement and stimulation. Sometimes you do see a micro lesion effect even with the microelectrode, but this is much more common with the macro stimulating tip and also with placement of the electrode itself. Following a period of microelectrode recording and stimulation, the lead itself is placed. Once the neurologist and neurosurgeon are happy with the results of microelectrode recording and macro stimulation, the actual deep brain stimulation electrode is implanted. This is done by adding an extension to the microdrive, and the electrode is secured in place using the Guardian cap system. We then rotate the top of the frame backwards, and this allows us to remove the entire electrode from the microdrive and place the distal end under the scalp for attention during stage 2. So once I have removed the distal end of the electrode from the microdrive, we place a cap over the end of it, and then I bury the distal electrode under the scalp in a pocket that I've made at the start of the operation. After the CRW frame has been reset with coordinates being programmed for the second side, the whole process starts again. These are the tubes being placed into the brain through which the microelectrode recording and macro stimulation electrode will be placed, and ultimately through which the deep brain stimulation electrode will be placed. After microelectrode recording has been undertaken, the next step is macro stimulation. This is where we pass an electric current through the stimulating portion of the electrode and assess any clinical changes that occur. Not only are we looking for benefits in terms of the patient's tremor, rigidity and bradykinesia or slowness, but we're also looking for side effects. Side effects can include speech impairment, muscular contractions, pins and needles, or disturbance of eye movement. All of these side effects give us clues as to whether we're in the correct area and which direction we might need to move the electrode if we do need to reposition. This is the deep brain stimulation lead being placed through the extension which has been attached to the top of the microdrive. You can see that extension there. It's important to put that extension on because if you forget to do that, the electrode can end up being placed much deeper and in a very dangerous location. Measurements need to be made from the end of the electrode in order to make sure that the white stop is placed in the appropriate position. It's important to pay attention to detail at that time because any error in positioning of the stop will result in a significant error in electrode positioning. Stage 2, placement of the extension leads and implantable pulse generator. Once the electrodes have been positioned and their distal ends have been placed under the scalp, the wound is closed. The second operation, also known as stage 2, is done with the patient asleep, whereas the first procedure was done with them awake. During the second operation, we are connecting two extension leads to the distal ends of the deep brain stimulation electrodes and tunnelling them down from the head to the chest, where we connect them to the implantable pulse generator, which is buried in a subcutaneous pocket. The first step in this operation, after the patient has been prepared and draped, is to make an incision below the clavicle and to create a pouch beneath the skin and beneath the pectoral fascia. This pouch is where the battery will ultimately be placed. Once the pectoral pouch has been fashioned, the second incision is made over the scalp, just overlying the distal end of the deep brain stimulation electrodes. It's important to be careful not to damage the electrodes during this part of the procedure. Many surgeons prefer not to use monopolar diathermy during this part of the operation, however, in my experience, if one uses relatively low settings and is careful, it can be utilised without any harm. The next step is to prepare for tunnelling. Tunnelling involves placement of a tube beneath the skin, and this runs from the head to the chest. This creates a conduit through which the extension leads can be passed. This is the tunnelling device, and I'm inserting this at the level of the scalp and advancing it beneath the skin, down the neck, and eventually over the top of the clavicle or collarbone. It's obviously important not to go underneath the clavicle because that would be disastrous. Once the tunnelling device has been successfully passed to the chest wound, the extension leads are then passed through the tube. These are the extension leads being passed down through the tunnelling device to the chest. It's important to maintain sterility, particularly during this part of the procedure, by minimising handling of the components and minimising any contact that these components might have with the skin. One hopefully reduces the risk of infection. Once the extension leads have been placed through the tube, the actual tunnelling device is removed and the extension leads are connected to the ends of the deep brain stimulation electrodes. Remainder of the extension leads are then pulled through. At this time I'm removing the temporary covers from the distal ends of the deep brain stimulation electrodes so that these can be plugged into the extension leads. I'm now pulling the extension lead down. Once the extension leads have been connected to the ends of the deep brain stimulation electrodes and tunneled to the chest, they're plugged into the implantable pulse generator. Again, I'm careful to minimise any handling of the IPG in order to reduce the risk of infection. I often use betadine-soaked packs in order to avoid directly touching the components. Once the battery has been connected to the extension leads, the subcutaneous subfascial pouch is irrigated and we check to make sure that there's no significant bleeding. The battery is then placed into the pouch, and it's important that the writing is directed towards the skin and not towards the pectoralis muscle. Again, at this time we try to avoid any direct contact between the battery and the skin edges to minimise the chance of infection. Once the battery has been positioned, the wounds are carefully closed. This is Professor Richard Bittar, neurosurgeon from Precision Neurosurgery in Australia. I hope this presentation assists you in understanding how the surgical procedure of deep brain stimulation is carried out. It's important to note that different surgeons do this procedure in different ways, but there are a number of common elements that would be shared by all surgeons.